colleague, Lucy, who is also going to take a movie forward from here. Lucy, over to you. Over.
Hello, everyone. Sorry, I have connection problem, but it's okay. Do you hear me? Hello. Yes. Okay. Good afternoon, everyone. Today.
Yes, Lucy, we can hear you.
And technician with a master's degree in management, quality, security, environmental, and expert in hospital hygiene. I am IPC technical advisor at Jhpiego, Burkina Faso, in 2 programs: global health security and integrated health service. Today, I want to facilitate the session with Blossom. And the objective of this session is to speak about the IPC programs, the IPC WHSPC score components, and the IPC assessment tool score for health facility, and international health regulation and IPC. We have 2 speakers. The first speaker is sorry. The first speaker is Dr. Sobhan Kadi. You want to speak about infection prevention and control and WOH program core components. I want to say that Dr. Sobhan Kadi is co-chair the founding of the member of Jhpiego prevention and control infection, and he is working as a technical advisor in infection prevention and control with Jhpiego, Pakistan, and to support Ministry of Health in IPC programs and healthcare associated infection. He is a medical graduate with 2 postgraduates in public health and another in healthcare system management. He has also experience in global health security agenda, infection prevention, control, disease surveillance. You want to speak about infection prevention and control. The second speaker is Emmanuel Nino. He is also founding member of Jhpiego COP infection prevention and control, and he is a focal lead, a IPC lead in reaching impact saturation and epidemic control in Ghana. He is a nurse and he have a master's degree in public health. So I want to say welcome to Dr. Sobhan. He wants to speak with us in infection prevention and control programs. Welcome, Dr. Sobhan.
Thank you, Lucian, and I would like to welcome everyone here. Just give me a minute. I'll start my presentation. Can everyone see it?
Yes, thank you.
Thank you. Once again, on behalf of COP of Infection Prevention and Control, I welcome everyone who is here, and we'll be discussing about Infection Prevention and Control Program, its core component, and international health regulations. So the basic objectives are to learn about what exactly IPC is all about, what is the component of different program, and how we can assess our health facilities on the basis of that core component. Before moving forward, I would request everyone to let us know what they think that what is infection prevention and control program. So if someone comes and asks you, what do you think, what's IPC program? So what would be your answer? You can write your answer in the chat box. I'll give 15 seconds and then we'll come toward the next slide. So you may write anything you think about IPC program. It can be, you can write just a hand hygiene. You can write different core components. You can write anything, but whatever it is in your mind, you can write what you think about IPC program. And then we'll move toward the second slide. Okay, you write your answers in the chat box and then we'll come back toward it. Yeah, I can see different answers on that. So the next component, so what is actually infection prevention and control program? A program that must be structured to be successfully guide, assess, and support different IPC activities. So it is not just about hand hygiene. It is not just about any other component, standard precaution, transmission-based precaution. It is group of all activities that is being supported by a holistic and systematic way that would be called an infection prevention and control program. The program must acquire and retain these attributes. It should have designated staff. I'll repeat this component again and again. What does that mean? A designated and dedicated staff. It should have IPC leaders who support the program. A farmer authority should be there. Tangible support from the health leadership, health facility leadership. There should be resources. Nothing is possible without resources, my friend. And then there should be partnerships and effective communication. We'll come again when we'll be studying different core component and we'll discuss each and every component there. So why infection prevention and control is important and why we are actually discussing it. If we have an effective IPC program implemented, it will reduce HAI up to 30%. In fact, more than 30% HAIs. So if serverless component is implemented properly, it may reduce healthcare associated infections up to 25 to 57%. And improving hand hygiene alone may reduce the pathogen transmission up to 50%. So whenever there is the reduction of infection in the health facilities, we all know that it improves the healthcare quality. It ensures patient safety. It also makes sure that healthcare workers are not overburdened. And then it will save a lot of money. We'll discuss in the component of HAIs. So after that, we'll move toward core component of infection prevention and control. We all know that there are multiple organizations working in different countries and different parts, and they have their own, I would say, definition of IPC program. So there was a need that there should be one standardized IPC program. That's where WHO came and they developed a minimum requirement and core components of IPC. These all core components, if I am working in any health facility and I claim that I have been implementing IPC program, I should cover all these 8 core components. That's it all about. So we'll come again. So these are 8 core components. And what are those? Infection prevention and control program, the governance mechanism, guidelines, education and training, HAI surveillance, multimodal strategy, monitoring and evaluation, workload staffing, and build environment. So we will discuss each and every component in detail, and then we'll go toward the IPCAF tool, IPC assessment tool for the health facility. So infection prevention and control program, it's mainly addresses the governance mechanism. how a program should be in the health facility as well as in the national level. Who should lead it? And all other related aspects will be discussed in this IPC program. So at national level, an active stand-alone national IPC program. I'll repeat this component again, an active and standalone. The program should be active. It should be dedicatedly on infection prevention and control with clearly defined objectives. And these objectives should be supported by the budget and microbiology lab. And same would be at the health facility level. There should be clearly defined objectives, but based on the local epidemiology and the priorities. So the priorities and outbreaks of, I would say, the infections in Pakistan might be slightly different as compared to the infections in the hospitals of in Cuba, and so on. So whatever the program objectives are, it should be dependent upon that epidemiology of that country. It should have clearly defined objectives. Annual action plan should be there because everyone should know where they actually want to go, right? It should have a dedicated team, dedicated and trained team. We'll see in the tool component. But here I would just say, for instance, in a hospital, we are working as an organization, we are supporting. So there is a person who is IPC focal person, but he has multiple different responsibilities. He also manages the admin work. He also has patient safety. He has also, he manages some ward, etc. So will that person be called as a dedicated HR on IPC? Of course not. So dedication demands a dedicated time. There are some more clarity on, because when there are, in a hospital, there are beds less than 250. There is a provision that an IPC person can be part-time, and that's also in the primary healthcare. But in a major hospitals, IPC person should be dedicated one. There should be a good microbiology lab that supports IPC program. So the next component is IPC guidelines. So development of IPC guidelines is actually, I would say, a complex mechanism. So we cannot expect every health facility that they are developing their own IPC guidelines, but they should have a trained staff who is capable of, adopting national IPC guidelines, and those guidelines should be resemblant to that of international guidelines. So when we say that IPC guidelines should be in the health facility, it means that those guidelines are accessible to every person. And every person, I mean, every healthcare provider has access to those guidelines. They know how to, for instance, the hand hygiene, how to wash their hands, and all other aspects as well. So those guidelines should be there. Health facilities should have the expertise to use those guidelines, to adopt those guidelines. And then there should be resources. And then there is another factor, that is the monitoring of those guidelines. We have implemented the IPC guidelines, but is it properly being implemented or not? And there is another question here. For instance, the director of a hospital has all those guidelines on hand hygiene, standard precaution, transmission-based precautions, HEIs, etc., etc. So can we say that that hospital has IPC guideline component as a part of IPC core component? I doubt it, because those guidelines are just placed in one office. Otherwise, the guidelines should be with each and every healthcare provider who has to work in the health facility: doctors, nurses, paramedical staffs, and last but not the least, janitor staff. Janitor staff is actually, at the more risk as compared to any other healthcare worker in all hospitals and health facilities, but unfortunately mostly neglected in lower middle income countries. So that's the second core component. The third core component is education and training. So we have IPC program, we have the guidelines, so there is a need to train the staff. There should be pre-service training, there should be in-service training at least annually, and then there should be refresher trainings. When we say that every healthcare worker should be trained on infection prevention and control, it doesn't mean that he or she should be trained by PPT presentations. IPC is a practical field. So whenever there is a training, it should be on bedside. Our simulations can be there, of course. So there should be IPC program at the national level as well as on the health facility level that ensure that the training of healthcare workers is there. IPC training can be part of different, I would say, those of clinical services. Surgeons, nurses, physicians, they should have the education and training on infection prevention and control during their training period. The next core component is surveillance of healthcare associated infections. So healthcare associated infections, there are many countries who don't have any data on HAIs because they are not reporting those HAIs. So HAIs, whenever there is an infection, so I would say healthcare associated infection is reported, what will happen? The healthcare quality will go down, patient will suffer. Third part would be healthcare providers would be overburdened. And last but not the least, health facility will have to face a lot of cost. Over $20 billion are spent on HAIs in USA in 1 year. So you can imagine how costly it can be in different countries. So whenever there is a healthcare associated infection, there is a great chance that more antimicrobials will be prescribed. When there is more antimicrobials prescriptions, there is a chance of antimicrobial resistance. So there should be surveillance of HAIs, but it is not possible by just saying it that the hospital should report all HAIs. There should be budget. Leadership should be committed to conduct those HAI surveillance. There should be information technology component. I mean, a few hospitals can report it through their HMIS component, other can report it through apps, etc. So it would also need case definitions, methods, lab support, and quality control. So at each health facility, there should be HAIs reporting. And those are definitely COTI, urinary tract infections are there, surgical site infections are there, CLEPC is there, and ventilator-associated pneumonia is there. So that's where there is another question, and I actually wanted everyone to answer that. What do you think? Which country has HAI reporting on a national level? For instance, if I am working in one country, so I'll answer in the chat box that I belong to this country and we are reporting on HAI on national level. So which country has HAI reporting on national level? And data is easily accessible as well. So you can write your answer in the chat box. For instance, I can write Pakistan. So 90% or 80% data is being reported. It is easily accessible. And the reporting channel is, for instance, DHIS2, or it is an app. So I'll stop here for 15 seconds and I'll then come back and we'll start toward the next component. Yeah, of course, in US, it is reported. Any other country? Yeah, I would like to hear about any middle income country or lower middle income country. So, that's actually the tragedy that most of the middle income countries don't report on HAIs. That's great. Rwanda, they are reporting on HAIs on national level through their HMIS system. That's great. And Mr. T has also raised the question about South Africa. So as per HAI surveillance, there should be reporting of HAI on national level. So we'll move toward the next core component because of the time issue. And that is one of the most important component. It is multimodal strategy. Whenever we say that we are going to implement one thing, we should provide an enabling environment. That's the point where multimodal strategy comes. So IPC programs should coordinate and facilitate implementation of IPC activities through multimodal strategies. For instance, we want the compliance of hand hygiene in one hospital or in one ward. So we'll have to provide the infrastructure of hand hygiene. We'll have to provide the hand hygiene stations, its supplies, its position, it is on the right place or not. Once we have that built-in component, then we'll have to teach the healthcare workers. After that, we'll have to monitor it if they are actually, what is the compliance of it, hand hygiene. And then we'll have to acknowledge all those who are actually doing it. And then we'll have to make it a behavior and a culture of the health facility. So that's actually the multimodal strategy, and that component can be in every activity we want. It can be in reduction of surgical site infection. It can be in improving occupational health, etc. The seventh component is monitoring and audit. So we cannot keep a program as such and without a monitoring and audit component. The seventh core component is workload staffing. You might have seen such pictures in many hospitals. There are 3 babies in one bed. So whenever there are more patients on one bed, they are sharing the infections. So there are more chances of infections, right? And then staffing load is also important, and bed occupancy. Whenever there is overcrowding, there is a chance of disease transmission. So there should be one bed, one patient policy. There should be at least 1 meter distance between different beds. And healthcare worker staff should be as per the criteria. So as per WHO criteria, one dedicated IPC person, technical person, should be there in less than 250 beds. Although the new research shows that one person should be for 100 to 125 beds. But at least there should be IPC for, I would say, the trained persons. 8th core component is built environment, materials, and equipment. So we are talking a lot about IPC. We are providing guidelines. We are providing trainings, but staff does not have the equipment and supplies. So how they will implement it? So that's why there is an 8th component, that is to provide built environment should be as such to support IPC. There should be safe and reliable water supply, functioning hand hygiene, station should be there, continuous power supplies should be there, PPEs and patient placement should be as per the protocols, medical waste management system should be there, decontamination and sterilization services should be there. So next component is IPC assessment tool for health facilities. So WHO has also released those assessment tools so that we can assess our health facilities where we stand. The tool is also for the acute care. It's also for the primary health care. So I would love to know, how many people have used this tool, but due to time deficiency, I'll move forward to the next slide. So that tool, because we know that it revolves around 8 core components. So every core component has 100 marks. So you will go in, in your health facility and you will score as per all those criteria and checklists, and then you will see where you stand. If your health facility score is less than 200 out of 400, less than 25%, then it is inadequate. If it is 200 to 400, then it is basic one. If it is 400 to 600, it is intermediate. And if it is between 600 to 800, it is advanced one. So here I'll show the IPCAF tool. I'll not take much time, but I actually want all to have a look how that checklist look like and how to fill that tool in your health facility. Just give me a minute. So everyone can see it?
Yes.
Thank you. So that's the tool. And it has, all components. First component is infection prevention and control program. So for instance, do you have an IPC program? And if the health facility has then you will give 5 marks if it does not have defined objectives. If there are defined objectives, then you will mark 10 marks. If the IPC program supported by IPC team comprising of IPC professionals, if no, then you will give it 0 score. If there is a team, but only an IPC focal person, then 5. And if there is a complete team, then it would give 10 marks. Similarly, if I'll go, toward any other aspect, does the IPC team include both doctor and nurses? If yes, you will give it 10 marks. If no, then you will give it 0 marks. The second core component is of guidelines. So does your health facility have the expertise in IPC and infectious disease for developing or adapting guidelines? If yes, then 7.5 score. If no, 0. Does the health facility have guidelines available on standard precautions? Yes, 2.5, and everything will have 2.5 marks. Here, when we say available, it means that it is available in each and every ward. It doesn't mean that it is placed in any office of the director. Similarly, there is the third component, that is education and training. So are there personnel with IPC expertise to lead the IPC training? If a health facility has dedicated and trained staff who can conduct training of IPC, then you will give 10 marks. If health facility does not have any such person and they have to rely on the partners, for instance, Jhpiego or WHO, then that health facility will get 0 mark. How frequently do health care workers receive training? Never or rarely, then it will get 0 marks. New employee orientation only for the healthcare worker, 5 scores. New employee orientation on regular IPC trainings for healthcare workers is offered, but it is not mandatory. So it will get 10 marks. But if it is mandatory then it will get 15 marks. So similarly, different questions will come. And then fourth core component is healthcare associated infection. So do you have personnel responsible for the surveillance? If yes, 5 score. If no, then 0 score. Similarly, have the professional responsible for the surveillance activity been trained on basic epidemiology, surveillance, and IPC? Yes, 5 score, and no, 0. So that's how the whole tool work. What are the methods? And then there is multimodal strategy, system change, education and training that we have been discussing the build it and teach it, sell it. Then the sixth core component is IPC practices. I would apologize here because the time is short, so I'm trying to finish it as soon as possible. So my speed might be a bit faster. So monitoring and audit component. So is which process and indicator do you monitor in the facility? So if you monitor all these indicators, hand hygiene, 5 scores, IV catheter insertion and its care, 5 scores, wound dressing, 5 scores. When it says that the monitor, it means a systematic way that is continuously monitoring these things. It doesn't mean that once you are conducting that assessment, suddenly someone comes and trying to show that they are monitoring that catheter insertion, it will not get any score. So there should be a program rolling on continuous basis. The second one is workload staffing. So is adequate spacing more than 1 meter between patient beds? If yes, but only in certain departments, 5. If it is in all departments, 15 scores. Similarly, it is the built environment. And then in the end, it also give, the subtotal and then detail of this scoring. So that's mainly, that's actually, the main component of infection prevention and control. So whenever we are implementing infection prevention and control programs, we should keep it in mind that all these factors should be there. So I'll wait for your questions in QA section as well as in the chat, and we'll come back in the end and we'll try to answer as many questions as it is possible. While during the next presentation, I'll also try to answer it in the chat box. From here, I'll hand it over to my colleague Blossom, and then we'll meet in the end of this session. Thank you, and over Blossom.
Thank you, Dr. Sovan, for taking us through the attributes that of IPC program should be structured. in order to be successful, as well as speaking to us about the WHO 8 component of IPCs. Thank you very much.